Hello everyone, Anthony here from Succeeding in Nursing School, and today I'm going to be discussing acute lung failure, also known as acute respiratory failure, and acute respiratory distress syndrome, or ARDS. In this video, I'll be going over causes, signs and symptoms, significance, course of condition, and treatment. To start, we'll begin with acute lung failure. Acute lung failure is the most common type of organ failure seen in critical care, and is characterized by pulmonary dysfunction resulting in an inability to maintain adequate gas exchange. Acute lung failure occurs by means of secondary condition of injury and is broken up into two categories. There's hypoxemic normocapnic and hypoxemic hypercapnic. For hypoxemic normocapnic, it is defined as having a PaO2 of less than 60 while maintaining a PCO2 within the normal range. This category is generally the result of intrapulmonary causes that result in some kind of VQ mismatch or intrapulmonary shunting. These causes can include pneumonia, cystic fibrosis, pulmonary embolism, ARDS, asthma, COPD, inhalation of toxic chemicals, and near drowning. Our other category of hypoxemic hypercapnic is defined as a PaO2 of less than 60, in addition to a PCO2 that is above 45 millimeters of mercury. This category results from extrapulmonary causes, resulting in alveolar hypoventilation, so gas exchange isn't able to occur and we're retaining extra CO2. So causes of this would be head trauma, drug overdose, MS, Guillain-Barré syndrome, myasthenia gravis, pleural effusion, pneumothorax, massive obesity, sleep apnea, and a few more. Treatment begins with oxygenation, but the method varies based on the issue. For some people, supplemental high-flow oxygen may be sufficient. In the cases of alveolar hypoventilation and intrapulmonary shunting, however, the use of positive airway pressure is going to be needed in addition to supplemental oxygen to permit gas exchange. As always with supplemental oxygen, you need to be cautious in the amount to prevent oxygen toxicity and hypercapnia. Patients with a pH of less than 7.25 have shown to have an increased need for mechanical ventilator use, so when you get the initial ABG results back, and if they have a pH below 7.25, more than likely they're going to be put on a ventilator. For mechanical ventilator use, the normal PCO2 for the patient needs to be taken into consideration. It's mainly going to be an issue for COPD patients, as this is common, and then we're going to do what is called permissive hypercapnia, or permissive hypercarbia, whichever term is going to be used, a state where we allow an elevated CO2 level to persist. The reason we do this is to decrease the workload of breathing, because for these patients, CO2 is what drives their effort of breathing, and we're going to maintain cerebral perfusion. So if you didn't know, CO2 is a very potent cerebral vasodilator. So when you have hypercapnia, your cerebral arteries are actually very dilated. So if we take this away, we're constricting the cerebral arteries, which can then result in ischemia or a stroke in the brain. Alongside this, we're going to be using pharmacologic measures. So we're going to be using bronchodilators such as beta-2 agonists, anticholinergics to aid in muscle relaxation and decrease secretions, sedation in order to assist the patient while maintaining adequate ventilation, decrease the work of breathing, and increase the comfort of the patient. And then corticosteroids to also decrease airway inflammation, and they also enhance the effect of beta-2 agonists. Nutrition is important, but it's a tricky area with acute lung failure, as both malnutrition and overnutrition can cause significant problems. Malnutrition has the obvious issues of not providing enough adequate nutrients and protein for the patient to recover, while overnutrition occurs a little bit less frequently, as most hospitals are kind of reluctant to overfeed the patient. They usually start very slow. Well, what happens with overnutrition is you actually cause an increased production of CO2, resulting in increased pulmonary demand, meaning the patient's going to try to breathe more, so it's going to have increased respiratory muscle fatigue, and we don't want that. Complications include all those attributed to immobility and stress that you should know at this point. So immobility, you're looking at decreased bone density, resulting in hypercalcemia. VTE, stress ulcers, cardiac dysrhythmias. And then for all these, VTE, obviously you're going to do your prophylactic blood thinners, usually just sub-Q heparin. For GI stress ulcers, typically you're going to want to get them off mechanical ventilation as soon as possible. If that's not the case, then you're usually going to be using some kind of PPI or H2 antagonist to kind of decrease the amount of stomach acid in there or decrease the pH of it. For hypercalcemia and decreasing bone density, this is going to be your passive range of motion exercises you're going to want to keep working on, maintain bone density, try to prevent muscle atrophy as much as you can. And cardiac dysrhythmia, that one's more of a matter of knowing your risk factors, managing what risk factors the patient has, and then just kind of going from there. An additional complication of acute lung failure is the transition to ARDS, which is what we will now discuss. ARDS is a systemic process that is considered to be the pulmonary manifestation of multiple organ dysfunction syndrome, or MODS. It is characterized by non-cardiac pulmonary edema and disruption of the alveolar capillary membrane as a result of injury to either the pulmonary vasculature or the airways. ARDS is also characterized by its unique progression, where in the first 24 hours, the patient's ABG and X-ray may appear normal, where after this 24-hour period, bilateral opacity with no pulmonary explanation appear and severe acidosis develops. So ARDS has three distinct phases. There's the exudative phase, the fibroproliferative phase, and the resolution phase. The exudative phase occurs within the first 72 hours, give or take, of injury, and is characterized by release of chemical mediators, damaging pulmonary capillaries, and changing vessel permeability. This damage causes leakage of fluid, blood cells, extra chemical mediators, and fibrin into the lungs, and results in development of microthrombi. Because of this, the lymphatic system soon becomes overwhelmed, resulting in pulmonary interstitial edema that causes alveolar collapse. Hypoxemia occurs as a result of intrapulmonary shunting and VQ mismatch secondary to compression, collapse, and flooding of the alveoli. Hypoxemia and the increased rate of breathing leads to patient fatigue and the development of alveolar hypoventilation. So now we have both causes of acute lung failure being exacerbated at once. Pulmonary hypertension occurs due to the damage to pulmonary capillaries and cause right ventricular dysfunction, resulting in decreased cardiac output. And that mainly classifies the exudative phase. Like I said, during this phase, the first 24 hours, the patient may appear normal. Their ABG will actually probably appear alkalotic as they're going to be hyperventilating to accommodate for decreased alveolar presence as it's being collapsed. But the post 24 hours, where you see the bilateral opacities and you see the ABG changes start to develop, that's when ARDS is starting to fully set in and this exudative phase is taking over. The fibroproliferative phase is described as a disordered healing characterized by enlarged and irregularly shaped alveoli and scarred pulmonary capillaries. So this is going to result in further stiffening of the lungs, increased pulmonary hypertension, and continued hypoxemia. So even after all the mediators have run their course, this disrupted healing is going to cause even further issues. It's not until the resolution phase occurs, which is over several week period, that structural and vascular remodeling reestablished the alveolar capillary membrane. Treatment of ARDS is multifaceted and begins with ventilation. Low tidal volume therapy should be done with the goal of maximizing tidal volume while maintaining low end pressure, about below 30, to minimize barotrauma to the esophagus and trachea. To compensate for the lower tidal volume, respiratory rate is usually going to be increased to about 20 to 30 breaths, but this is going to be dependent on the patient's pH and the patient's PCO2 levels. So for ARDS, permissive hypercapnia is used pretty commonly, and you generally want to keep it below 80 to 100 millimeters of mercury, which is a very high number, but we need to make sure that we're not overventilating the patient and causing too much trauma. The only time we wouldn't use permissive hypercapnia is if the patient has increased ICP, they have a history of seizures, or they've had seizures in the hospital during their stay, they have excessive pulmonary hypertension already, or they have heart failure going on, as this is just going to completely exacerbate it. Arterial pH of these patients is maintained at about 7.20 or greater through the use of either adjustments of tidal volume and respiratory rate or IV sodium bicarb. PEEP will need to be implemented as well in order to manage hypoxemia. The purpose of using a PEEP in ARDS is to improve oxygenation while allowing the titration of FiO2 down to a less toxic level, on top of its other benefits, including opening and stabilizing collapsed alveoli. PEEP, however, also causes a positive interthoracic pressure, resulting in decreased venous return to the heart and increases the risk of barotrauma to the patient, especially when it's above about 15 centimeters of pressure. Prone positioning is also very beneficial in the treatment of ARDS and is thought to be related to either the majority of lung tissue damage being done to the dependent areas of the lungs or due to an increased expansion of the lungs when in the prone position. When you think about it, going back to our lungs anatomy, the bulk of our lung is towards the back of our body. So when we place someone prone and we're pushing air in, it's allowing the entire backside of the lung to rise up. Whereas normally when we're standing, we have our scapula retracted and we're more pushing out with our body. Another treatment thing that we're going to be focusing on is maintaining adequate cardiac performance and tissue perfusion as the next highest priority, and it will be done through the use of inotropic medications, diuretics, vasoactive medications, so your vasopressors, and fluid restrictions. So you want to remember that these patients do have excessive pulmonary edema, so we are restricting fluid. ARDS shares the same complications as ARF, and the rest of the treatment focuses on ensuring comfort through sedation and analgesic use while monitoring and preventing complications. That will be all for this video. If there's another topic you guys want to have discussed, leave it in the comments and I'll look at it and go over it. My next video is probably going to be either another pharmacologic video or I'm going to be tackling sepsis, which is going to be a very long and thorough video. Like and subscribe if you enjoyed the video, and thank you.